Assalamu alaikum everyone. Good morning, good evening, whatever time zone you're watching this in. Okay, so let's begin, inshallah, today's session. And we are going to cover pilocytic astrocytomas today. Okay, so the format from today is going to be we are going to cover pilocytic astrocytomas today. This one is going to be a radiology heavy session because pilocytic astrocytomas have a very interesting radiological spectrum, and I wanted to share a lot of it. So we are going to have a general overview of them today, while we are going to continue with the subtypes, especially the cerebellar pilocytic astrocytoma, the optic pathway piloastros, and the brainstem piloastros. The main subtypes, we are going to cover them on Sunday because we run these live sessions from Sunday to Thursday. So today is going to be the last live session of this week. All the previous recordings have been up except from the question answer session that I'm going to upload today, inshallah. And there is another one which was with Dr. Itizaz, the yesterday's session. That one is also going up either today or maybe tomorrow. So, without any further ado, since this is a radiology heavy session, does someone want to unmute themselves and narrate the radiology? This one is really easy. It's a classic picture.
Yes, Dr. Kawal, can I try?
Yeah, sure. Yes, you can, Dr. Sana.
Thank you. This is an T1 weighted MRI image sagittal section with contrast showing a solid and cystic lesion in the cerebellum, and with the nodule is contrast enhancing and the cystic portion is not taking contrast, and there is a septation in it, and there is other no other positive findings are visible.
Okay, so I think the differential is pretty clear. What is it? What do you think this is?
My differential diagnosis will be a pilocytic astrocytoma or a hemangioblastoma.
And how are you going to differentiate between both of them?
On the basis of vascularity.
Yes. And does it make any difference if the cyst wall take up the contrast or not?
Yes, yes, there is a difference. If the cyst wall take the contrast, then it is necessary to take out the cyst because it is a false cyst. If it is not taking the contrast, you need to just take out the nodule of the lesion. That is enough.
Yeah, that's right. So we move on to the next one. Can someone volunteer? If nobody volunteers, then Dr. Sana can continue.
Okay, I can go.
Yeah, yeah, Dr. Sen. Yes, you can.
Yes, this is a multiple sections CT with contrast. I think for child, I have sagittal coronal and axial section. You can see a mixed cystic and solid component with calcification, I think.
Yeah, do you want to make any other comment? No? Dr. Hussain, you're not audible. I think he dropped out, maybe connectivity issues. So what is going on supratentorially here? Acute hydrocephalus, right? And we can also see some PVL here. There is edema around, even though the images are pretty low resolution, but we can be very sure that yes, there is a hydrocephalus, and there is a solid cystic lesion in the posterior fossa on in which the solid component is showing some calcifications as well, and it's also taking up contrast. So, moving on to the next image, these ones are pretty stereotypical for how pilocytic astrocytomas usually look. What do you think about this one? Can someone else volunteer, please?
I am sorry for the bad connection. I've
Yeah,
been disconnected.
that's completely okay, Dr. Hussain. Do you want to continue with this image?
Okay, this is a coronal MRI T1 showing
Are you sure this is T1?
intraventricular شو شوي ما I I cannot tell if it's a flare or T1.
This is flare. This is flare. When you see
Oh,
this image here, do you see this slight hyperintensity around the ventricular walls? This is flare.
okay. This is the hyperintense intraventricular lesion extending both uh, into both lateral ventricles with hydrocephalus more prominent at the right lateral ventricle with heterogeneous intensity with heterogeneous intensity. There's also hyperintensity down the lesion. I think at the level of the thalamus.
Okay, is there any other sequence or anything else would you want to see to make up your differentials?
I would like to see the axial section and the T1 post contrast.
Why do you want to see T1 post contrast? What are your differentials here? What will be your most important differential here?
The intraventricular lesion, I would think about ependymoma or subependymoma.
Yes,
The
subependymoma
most
will
likely.
be a very, very important differential here because the location is very
Yes.
typical
Uh,
for
uh,
the foramen of Monroe.
One thing I would like to comment on the lesion looks like it's arising from the septum pellucidum.
Yeah, it does look like it's arising from the septum pellucidum. It's also
Yeah,
blocking the foramen of Monroe and
yeah,
going on the opposite side as well. There is ventricular dilatation on the right side, and we also see temporal horns, which are visibly dilated. So, the first and the most important differential in this scenario, as long as we have not seen the post contrast images, will be subependymoma. And after that, we can keep choroid plexus tumors, but this is not a very typical imaging for choroid plexus. It's also not so typical for central neurocytoma, but it's very important to rule out subependymoma here and maybe SEGA. But since we don't have contrast, there is a long list of differentials. But I'm sure pilocytic astrocytoma will not be the first differential that comes to our mind when we look at this image because this is not a very typical location. So, what do you think? This is the post contrast image of the same lesion. Can someone else volunteer
okay,
now? Is it okay with
okay.
you, Dr. Hussain, if someone else volunteers as well? We have a lot of radiology today, so I am going to need volunteers. Anyone else? We have Dr. Lalita with us as well. We have Dr. Yusra with us. Nobody is volunteering today. I have no idea what has happened.
Hello, hi, doctor. Yeah, okay,
Hello,
I'll
Dr.
try this
Lalita.
one. If no one is taking, I'll try. So this is a axial MRI, T1 post contrast. As we can see, there is a heterogeneous lesion in the ventricles. As we know, it's a lesion at the foramen of Monroe. It's irregular in shape, heterogeneous in nature. There is gross dilatation of the ventricles. I cannot really appreciate marked periventricular lucency here. The best would be to see on a T2 or a flare. So the lesion itself is irregular. There's area of necrosis in the center. Yeah,
Is it
globoid in nature.
enhancing?
It's yeah, it is enhancing, but it's heterogeneous.
Mm-hmm.
There is some areas of hyper intensity and areas of hyper intensity. So I wouldn't really consider pilocytic astrocytoma here as my first differentials.
Exactly.
I would probably think it's a mm, I don't know
Would you
if
keep
it's
Sega in your DDs here? What about Sega? Would you keep it here?
SEGA would be vividly contrast enhancing, if I'm not mistaken.
Okay, which it is not. There is
Yeah.
enhancement, but it's not avid enhancement. What about central
Yeah.
neurosarcoma?
If if I've been asked about spot diagnosis
Mm-hmm.
and giving only one diagnosis in this picture, I will give central neurocytoma.
Exactly, because it does give this
Yeah.
popcorn type
Yeah, yeah.
soap bubble appearance, and
Yeah.
centralized neurocytoma obviously enhances more avidly than this one, but it has this patchy enhancement pattern, which this one is following. Also, it is midline, it's arising more or less from the septum pellucidum. So,
Yes,
yeah,
that's the
central
it's called
neurocytoma would be the first one that comes to the mind. Sega can be there. Then we can also keep choroid plexus tumors as a far off differential, but we will not think of pilocytic astrocytoma when we look at this radiology. So, you're going to see a lot of other interesting images as well, and the point that I want to make today is how different in presentation is pilocytic astrocytoma, while the first thing that we have in our mind is a cerebellar lesion that is solid cystic in nature with a large cystic component and a mural nodule. So we have stereotyped it to one single radiological presentation, while even the textbook says, technically Greenberg is not textbook, but still a published book says that it has four very different radiological presentations. So here is another one. You have a supratentorial lesion here, right? And assuming that this is an adult, what do you think is happening here? Do we have volunteers?
I can go
I
on
guess.
looking
Okay.
question.
Yes.
Okay.
Okay, Dr. Kingsley, you can have your shot now. Everyone else has volunteered.
Okay, assuming this is an adult, I'll be taking more of possibly a high-grade glioma, GB or GBM metastasis. These are what I'll be thinking about if it's an adult.
Why would you think that this is a high-grade glioma? I'm just curious. What are the
Okay,
features here?
well, the location of the lesion first, and also the pattern of the contrast enhancement. There is an irregular ring enhancement with massive, looks like massive hyperintensity, suggestive of necrosis, sacral
Exactly.
necrosis.
And there is significant amount of perilesional edema as well. There's significant mass effect. There's midline shift. We see that there is the hydrocephalus there. The contralateral ventricle is enlarged. Ipsilateral is effaced completely. We also see the third ventricle, which is dilated, but it's pushed on the other side. And let me erase this one here. So, on this presentation, it does look like it's a pretty high-grade lesion. The imaging is very typical of GBM. You are right about that. There's irregular ring enhancement, and it's multicystic. There is an irregular solid component here, but the lesion is very well circumscribed. So, yes, you are right to think that this is more likely to be a high-grade glioma. Okay, somebody is writing in the chat box, Siafa Sando. So this one is a new name. Pleomorphic xanthoastrocytoma. Yes, we can keep that in the differentials. And Dr. Fatma Javed is saying that GBM wild type just on the basis of radiology. That's right. If I just looked at this radiology, I would bet that this is GBM. But now we know, since you all know the topic of today's session already, which I think is counterproductive, by the way. It takes away the fun of guessing. So this is a piloastro. Surprise, surprise, we have another one. I'll do the radiology so that we can move on to the text. Uh, this is a CT plane showing an ill-defined lesion on the left side involving the thalamus and the insula as well, causing significant amount of mass effect and midline shift. We see that the gyri and the sulci are effaced completely. Is my voice clear?
No,
Yes.
Dr.
Yes.
Kamal,
Yes.
previously
Is
it
it
was
breaking?
broken.
Yeah, because I did receive a
Yes,
message. So is it better now?
yes, it's
Yes.
better now.
Okay. So, Dr. Lalitha has already written in the chat box what this is. This is an optic pathway glioma. Yes, this is calcified, widely calcified. Again, not the very typical radiological presentation we see or associate with the pilocytic astrocytomas. This is mostly a solid lesion which is heavily calcified, and it does not have the solid or the cystic component or the mural nodule, which differentiates PCA. This one is even more interesting. What would you think of when you look at this radiological presentation?
Craniopharyngioma.
Exactly.
Come on.
This looks like a
Yeah.
stereotypical presentation of craniopharyngioma. The lesion is suprasellar, and you see slightly solid cystic heterogeneous, and there is contrast enhancement, but that is heterogeneous as well. So the location and the radiological presentation is very typical for craniopharyngioma, and I think it would be a surprise for anyone who sees the post-op biopsy that shows pilocytic astrocytomas. So it's always important to keep this in the mind that radiology can be very, very deceptive. And the best we can do is make a list of differentials. But obviously, histopathology is going to be the final word. Moving on. These are WHO grade 1 tumors. Most common astrocytic tumors in children. The prognosis is excellent. Why is the prognosis excellent? Because even if we end up doing subtotal resection, we can always go back and do a redo surgery to take all of it again, right? Favored locations, cerebellar hemispheres, we all know that. Optic pathways, hypothalamus, can also involve brainstem or spinal cord. So, brainstem has these. Which subtype of brainstem gliomas is this one? Usually,
DIPG.
no. DIPG is not PCA.
Oh, okay. Sorry.
There are 4 subtypes of brainstem gliomas, right?
Yes,
This
Yeah.
one is the one with the exophytic component. So
Yep.
the brainstem gliomas that are with the exophytic components are most likely to be pilocytic astrocytomas. Because what ends up happening is their cystic component is within the brainstem. I'll draw it here. Please excuse my poor drawing. Assume that this is brainstem. What ends up happening is this is the tumor and this cystic component is within the brainstem. So the outside portion, the region that I'm marking with the black color, this is what we take out. This is the mural nodule. It's the exophytic component. We can take this out and the cystic portion resolves and the patient gets completely cured. So if there is an exophytic component on a brainstem glioma, it usually is associated with very good prognosis. What were the other uncommon locations? Suprasellar, we saw. Intraventricular is also uncommon. Along with that, in the brainstem, midbrain is also pretty uncommon. Also, they are more common in children, but there are case reports. There were multiple case reports. In fact, when I was making this presentation and doing a bit of research, I did come across quite a few number of presentations that showed that they were present in the adult age group, even in 50s and 60s. So usually they peak around the second decade, but they can present in adult life. And the image that you saw of the supratentorial PCA, that was from the adult age group. So why are they so important? If a child is presenting with the stereotypical image of an optic pathway glioma or a cerebellar pilocytic astrocytoma, a very good thing to keep in mind is to assess them for NF1. Why? Because these are the most common CNS manifestation of neurofibromatosis type 1, And if you are getting a patient with PCA, always evaluate them for NF1. They might or might not have it, but you cannot exclude it from your history and examination. So, as I mentioned, they usually present during second decade of life, but they can also go in the adult life. Optic gliomas are the most common type in NF1. Let me change the slide. Okay, when we come to the molecular pathway, MAPK pathway alteration is most common, and in them we have BRAF mutations, some fusions. If you remember this, good enough. If you don't remember this, that's okay. BRAF mutation is one of the most common. MAPK pathway alteration. BRAF is a part of the MAPK pathway alteration. So this chart is from the Greenberg. I'm sure a lot of you are familiar with it. And there are four main categories. We already know them. I'll just highlight some of them. So the first one is a non-enhancing cyst with the enhancing mural nodule. The mural nodule is enhancing, it's taking up the contrast avidly, while the cyst is just there, it's blank. Then we have the enhancing cyst with enhancing mural nodule. And Dr. Sana did mention that if the cyst is enhancing, we have to take it out. Otherwise, if it's non-enhancing, we can leave it be. Because usually, if a cyst is enhancing, that just means that it might have formed a true wall. So if a true wall is there, if you don't end up taking this out, it might lead to some recurrence. So the other radiological presentation is a mass with non-enhancing central area or necrosis, which is very typical for GBM as well. This is how it looks like. And you can just think GBM, and you can also think the image that we saw a few slides back. There is a solid cystic irregular portion, and then there's a ring, and that is also a presentation of pilocytic astrocytoma. Sometimes it can also present as a completely solid mass, which is enhancing, and there is no cystic component. And this type is common for grade 4 astrocytoma. Let me write this. Astrocytoma IDH mutant, grade 4. So this is the classic radiological presentation for AIM. Sometimes pilocytic astrocytoma can also present like this. A solid mass with minimal or no cyst. So over 66% are cystic with enhancing mural nodule, and most of them have enhancing cyst as well, as mentioned here. Part of them will have non-enhancing cyst. Let me move on to the next slide. I have some more imaging ahead, by the way. Let's see if we get time to do them. What are the clinical features? Clinical features are going to depend on where the lesion is. Usually, it's going to present in a patient by the signs of raised ICP or the signs of mass effect. Common signs include headaches, nausea, ataxia, vision changes, etc., etc. And pathology is anybody who's appearing in the written exams in whatever boards they are sitting in. They have rhizanthal fibers and they have hair-like pilocytic cells, which is why they are named as pilocytic astrocytomas. So this is a slightly unusual presentation, and that is why I attached the key below the image. So what do you think is happening? There is a very small little lesion which is hiding behind the pica. I think you all can see pica here. This is where the pica is. These are the cerebellar tonsils here. And let me change the color so that you can make a good differentiation. This is where the cerebellar tonsils are, right? This is where the cerebellar tonsil is. And within the tonsil, on the right side, there's a small lesion that is hiding here with a solid cystic component. This region is solid, and then there is a cyst within it. It's so small, it's pretty easy to miss. And this is one of the rarer presentations, not very typical, but happens. So, does somebody would like to volunteer for this image? This is easy. This is pretty easy.
Okay, I can go.
Yeah, Dr. Sen.
Okay, I have axial sections, CT, T2 MRI, T1 MRI, post contrast and flare. The lesions I can see is the foreventricular lesion.
Is it a
The,
ventricular lesion? Where is the lesion?
in the CTS, it's a foreventricular lesion with hyperdense.
It's not a ventricular lesion. That is the catch.
Okay, let's
That is the catch. It's not a ventricular lesion. We don't see a ventricle here. What you're seeing here is a cystic component and a solid component. Let me mark this.
I
And
think the ventricle is pushed away to the
left
left. Is that
side.
correct?
Yeah,
Yeah.
this is where the ventricle is, right?
It's very sleep. Right? Yeah,
Yeah,
yeah.
this one is the ventricle. So this is not an
okay.
intraventricular lesion. Where is it?
It's a cerebellar. It's a cerebellar lesion.
Okay, it's cerebellar lesion. Where is it in the cerebellum?
Vermis.
Exactly, it's in vermis, and I was surprised that nobody read what was written in the smaller text
No,
below.
no,
And
no, I don't want. I don't want to read it.
yeah, that's being very
I want.
honest. I'd give you 100 brownie points, extra points for being so honest. And I was also thinking that I should minimize the font even more because when I'm making the presentations, they look very small. In the slideshow mod, they obviously get zoomed in. This is a vermian lesion, which is also not a very common location for pilocytic astrocytomas. Where do they usually present? They usually present here. They are hemispheric lesions. When we think of posterior fossa pilocytic astrocytomas, they are located in the cerebellar hemisphere. Vermian location is a rare presentation, rare enough to be reported, and you can still see that it is still following the solid cystic appearance with not a very big cyst, but there is some portion of a mural nodule. But still, if I look at this, pilocytic astrocytoma is not the first thing that will come to my mind. I probably would have thought a medulloblastoma, maybe a rare presentation. PCA would not have been my first line of thought. So, moving on. What do you think about this one? Do we have any other volunteers? Dr. Mustafa is pretty quiet today.
Yes. Yes.
Assalamu alaikum, ma'am.
Walaikum assalam. You have
Alaikum.
been very quiet today.
Can I?
Yes, ma'am. Assalamu alaikum, ma'am.
Walaikum assalam. So, would you like to volunteer for this image? This is very easy.
Yes, ma'am. Yes, ma'am. Of course, inshallah. The image on my left side is the flare image of the base of the brain, axial cut, showing the hypo-intense lesion at the level of the right CP angle, touching the tentorium. And the image next to it is the T2 weighted image, showing the hyper-intense lesion at the level of the right CP angle. And the third one is the T1 post-contrast image, axial cut, showing the hypo-intense lesion at the level of the base of the skull, right CP angle, and not taking the contrast.
So, what do you think? What will be your first differentials just based on this radiology?
It is a Uh, Epidermoid cyst, because dermoid occur in midline and epidermoid occur on the slightly off the midline.
Okay, so CP angle epidermoid cyst is your first differential. What will be your second differential?
Arachnoid cyst.
Yes, arachnoid is also a very close differential. What do you think of pilocytic astrocytoma when you look at this image?
Yes, ma'am, but the mural nodule is not appreciating.
Exactly, the mural nodule is not visible here, but this is a
I have
very uncommon presentation of pilocytic astrocytoma.
yes.
So the reason that I am putting all these uncommon presentations is to open up all of our horizons, that there are uncommon presentations of pretty common lesions. So there was this radiology uh, video that I was watching
I
on.
see the
Yeah, Dr. Sen.
I see the cyst is taking contrast.
Yeah, some of it. Yeah, it's
Yeah,
the wall is enhancing,
yes, the
but we
cyst is
don't
taking
see a
contrast.
proper nodule. We don't see a proper mural nodule. We're just taking up the contrast.
Even though they taking contrast or vivid enhancement of the cyst wall is entirely change the priority of the differential diagnosis.
Exactly. Then it
So
would put the
yeah,
epitomoid quite lower on the list, arachnoid as well. But epitomoid
yeah,
still
I can go.
enhance sometimes.
With this cyst, I can go uh, with rare presentation of pilocytic astrocytoma.
Yeah. So there was this
I could
radiology video on YouTube that I was listening to, and it said that uncommon presentation of common lesions is more common than common presentations of uncommon
of
lesions.
uncommon. Yes,
Yeah,
yes.
basically the
Uh,
point, he is a beautiful and very a competent neuroradiologist. I will try leaving the link in the WhatsApp group, and he makes some beautifully amazing presentations on neuroradiology, and I'm sure you would all learn a lot through him. So the point that he was trying to make was that you are going to find common lesions more often. The uncommon lesions are not going to show up as often in the clinical practice. So when you are looking at the imaging, keep the common things in the differentials first, because it might be an uncommon presentation of a very common lesion. So, what do you think of this one? I think this is the last one, or probably the second last one. We are also running out of time. The first image is flare, coronal section. It's showing a suprasellar lesion, and it's hyperintense, homogeneously hyperintense on flare. The second image is an axial section, the T2 weighted image. We see that it's hyperintense on T2 as well, but slightly heterogeneous in intensity, and the location stays same. So when we look at a suprasellar lesion that looks like this, what will you think?
I think I would probably consider differentials of optic chiasm glioma or craniopharyngioma. Maybe an upward point, I mean, an upward invading pituitary macroadenoma.
Yeah, they all
At
give
first,
me a very, yeah,
I
Dr.
will
Sen.
go. I will go with craniopharyngioma because it's cystic and solid. Yeah, it's small cystic component, but uh, at present.
Yeah, Dr. Fatma has written it could be cranio, it could be pituitary neuroendocrine tumors, it could be germinomas. That's right. It could be either of those. Suprasellar meningioma is less likely with this presentation. And yes, craniopharyngioma and germinoma, maybe pituitary tumors. Pilocytic astrocytoma is it's in the differentials, by the way. When we are talking about the suprasellar lesions, since chiasma is there, it can get involved in optic pathway gliomas, and it can present like this. So next time when you see a lesion looking like this, and you make up a list of differentials, and you have added up pituitary, you have added up craniopharyngioma, you have added up germinomas. Also remember to keep pilocytic astrocytoma in the list of differentials, especially when we are considering the suprasellar region. So, yes, I think this one was the last, and let me see. Yes, this one was the last. This is here because this is an exact replica of subependymoma.
Colloid cyst?
No, it's not colloid cyst. Colloid cyst is slightly lower. This is exactly at, and let me see, colloid cyst will be slightly here. This is above. This is a very good mimic of subependymoma. If you remember the Zoom session on myxopapillary and subependymomas, you would remember that there was
Yes.
this slide which was showing a lesion here at the level of foramen of Monroe, and it was very typical for subependymoma. So if I looked at this image, and if you see these, the second image is a post-contrast coronal section, and it's not taking up contrast. I would never keep pilocytic astrocytomas in my differential when I get this imaging. But this was a PCA. So radiology can be very deceiving, and I generally find neurosurgical patients deceiving as well. They can deceive you pretty quick. The imaging can deceive you pretty quick. So we all have to stay on our toes, educate ourselves, and like Professor Moody says, constant vigilance. I'm not sure how many of you have watched Harry Potter. I think most of you would have been. So, the profession that we are in demands constant vigilance, and that is what the radiology demands as well. That's it for today. We are 10 minutes late. Let's continue tomorrow. We are going to cover all the subtypes and also very brief surgical nuances, and that's it. Not tomorrow, Sunday. Thank you so much, everyone. Any feedback, any questions, all are welcome.
Uh, I have missed some sessions, so if you
I have uploaded
if you
almost
please
all of
can
them
upload,
on the YouTube,
uh,
Dr. Zen. There,
okay.
apart from one radiology Zoom session that happened yesterday with Dr. Itazaz, and there was one question answer session that was paired with myxopapillary and subependymomas. They are the only two videos that are remaining. Otherwise, I have cleared up all the backlog. So you can go on the YouTube channel and you can watch it via playlist. They are very neatly organized in the playlist. And who is this one? Xiaomi Redmi Note 9 Pro. I would really appreciate if you can write your names in the chat box. I will definitely share the radiology link on the WhatsApp group, inshallah. So that's it for today. If you have any questions that you were not able to ask during the session, you can always leave it in the group and I'll try and get back to you. Thank you so much.
Thank you, Dr. Kaval. Allah Hafiz.
Allah Hafiz. Thank you. Good evening, good night, whatever time zone you're in. Thank you.
Thank you. Good night.